Okay, good morning and good afternoon, everyone. Thank you so much for joining us for today's webinar on the Lugano Criteria Review. My name is Catherine Chintala, Project Manager at Merit. For those of you who are attending for the first time, we're delighted that you could join us. And of course, we extend our deepest appreciation to all returning attendees as well. In this webinar, we will be discussing the principles of the Lugano response criteria, as well as imaging modalities such as CT and PET. We will leave time at the end for any questions you may have. And not only will this webinar be a great introduction to this response criteria, but it will also provide helpful guidance on the application of Lugano in clinical trials. If you are joining us live for the first time, you may also view our previously hosted webinars on our website at www.meritcro.com under the Resources tab. You can select webinars to replay your on-demand webinar of choice. And we also host this content on our company's YouTube channel. Please note we are recording this webinar so that it can be added to both our website and YouTube channel for replay. All attendees will receive a follow-up email with a link to this recording, which we welcome you to share with fellow colleagues and industry connections as you see fit. All participants will be muted during the presentation. However, we will devote time to questions and answers at the end. We invite and encourage you to submit questions at any time throughout today's presentation via the Zoom Q&A functionality. Our presenters will address as many questions live as time permits, and all the remaining questions will be answered directly via email following this webinar. I am so pleased to be joined by my colleagues today, Dr. Jean Kim and Matthew Hoover. I would like to start off by introducing Dr. Jean Kim. Dr. Kim is Merit's clinical scientist. He has worked closely with our software developers and radiologists in order to deliver read workflows, functionality, and algorithms to support independent central review. His knowledge of various response criteria has been invaluable in implementing reading criteria into our EXCELSIOR software platform. Matthew Hoover is Merit's Oncology Partnerships Executive. Matthew brings a unique perspective to our oncology team and business development group. With a background as a registered nuclear medicine technologist, Matthew has extensive experience in both the business and patient side of clinical trials, and his knowledge of PET, NucMed, and CT is a great asset to our internal team as well as to our sponsors. And now, without further ado, I'd like to turn the presentation over to Dr. Jean Kim.
Thank you very much for your introduction, Catherine, and thank you everyone for joining our discussion today on Lugano Classification. So first, Lugano Classification is a tumor response criteria that is specifically developed for lymphoma. And our most recent 3 publications related to the Lugano Classification is a Dr. Cheson's Lugano Classification in 2014 with the Barrington 2014 mentioning other additional consideration. And then most recent publication was a 2023 prologue consensus, which is also a further update and clarification on Lugano classifications. Lymphoma is more cancer of lymphocytes involving multiple organs such as spleen, liver, nodal area, bone marrow, and etc. There are various subtypes of lymphoma exist, which the biggest delineation would be Hodgkin and non-Hodgkin. So the lymphoma, Lugano classification's common indication would be Hodgkin lymphoma and non-Hodgkin, which would be diffuse large B-cell or follicular lymphoma, and etc. And I'll pass our next presentation back to Matthew about the imaging modalities.
Thank you, Dr. Kim. The Lugano response criteria includes 2 different radiology imaging modalities within its classification system, CT and PET or PET-CT. The CT imaging is what I like to consider a 3D X-ray, well, because that's essentially what it is. An X-ray tube spins around the subject and rapidly takes a series of X-ray images of the patient from multiple angles. From there, the imaging system Algorithms create a 3D image which allow for viewing or interpretation of the images in the subject from virtually every angle imaginable. These 3D images do a great job of identifying disease and densities within the different body habitus, which help with identification, measurement, and assessment of oncologic lesions. As mentioned on the last slide, PET or PET-CT imaging is the second radiology modality that is used in the Lugano assessment criteria. It is important to note that the PET or PET-CT exam that is being assessed by the Lugano criteria utilizes fluorodeoxyglucose or FDG. This radiopharmaceutical is the most commonly used PET imaging agent and is highly accessible throughout the developed world. The sugar-based imaging agent is administered intravenously to the patient who arrives in a fasting state, usually 4 to 6 hours fasting, which follows a high protein and low carbohydrate diet the day prior to the exam. The rationale behind the patient preparation is fairly straightforward. Most cells use sugar as their form of energy to perform their typical cellular functions. The fasting and low carbohydrate diet ensures that the body has a low blood sugar and in a sense allows the cells to become hungry for that sugar or glucose. Once the imaging agent is administered, the hungry cells recognize the radioactive sugar in the bloodstream as a source of energy and take what they need out and deposit it into the individual cells, generally leaving very little FDG remaining in circulation within the bloodstream. Once imaged, generally 60 minutes post-injection, the exam will show areas of increased cellular metabolism. While PET-CT imaging with FDG is a very useful tool within oncology, not all lymphoma subtypes are FDG avid or demonstrate a concentrated uptake of the imaging agent. For these particular subtypes, it will be important to rely on the CT imaging data as the main modality for Lugano classification. One remark that I'd like to make before moving on to the next slide is regarding the images that we see here. Image A on the left is what we commonly refer to as a image or a maximum intensity projection. This 3D image is generally used as a starting point for readers to give a good overview of what's happening within the subject. Image B in the top right is a standard PET image, which helps to show the cellular function. For FDG studies, the increased FDG uptake typically indicates area of increased cellular metabolism. In the image below, C is a standard low-dose CT scan, which is used for two purposes. One, to correct for the PET image for areas of attenuation within the body habitus, and two, to help identify structures within the body. Finally, as we move to the last image, D, in the bottom right-hand corner, we have arrived at the PET-CT fused images. Basically, this is what the images look like when the radiology team merges or overlays the images onto each other and helps to determine exactly what is happening, where it's happening, showing the structure and function all within one image. This is a good example of an FDG PET-CT exam for lymphoma. While this image uses a different color scale than the previous slide, we can see two focal areas that appear to be hot. The brain, the largest consumer of glucose within the body, is a standard organ that tends to light up or have increased accumulation of FDG compared to other normal healthy tissues within the body. The other area that is visualized is the mediastinal lymph nodes, which would indicate that this is an area of concern where the cancer is located. Now, it is important to note that not all hotspots on the exam are malignancies. As we can see by the uptake and the metal wiring on the sternum, this patient recently underwent some form of chest surgery and is either actively healing or has developed an infection and is not malignant. This and so many other little nuances within PET-CT imaging and the whole of radiology in general are just a good reminder of why partnering with an expert team of radiologists is a critical component of your clinical trials. And so at this point, I'd like to hand the presentation back over to Dr. Kim.
Thank you, Matt. So back to our Lugano classifications. Measurability of lesion is also defined per Lugano, and they utilize both unidimensional and bidimensional measurement, which should be a short axis and long axis of the lesions, the simple distance, And then the bidimensional measurement would be measurement of the product of two values which are perpendicular to each other. And the measurability is also defined per Lugano classification, which the nodal and extranodal has the different size requirements. Nodal lesions would have 15 millimeters or greater in their longest diameter would be considered the measurable lesions. And then extranodal lesions would be 10 millimeters or greater in their longest diameter. This would be a little different compared to RECIST 1.1, which always the nodal lesions take the short axis. In the Lugano, there is no specification, so they will go simply with the longest diameter. And getting into a little more in-depth in lesion categories defined by Lugano is the target lesion, non-target lesion, new lesion, spleen, and FDG avid lesions, and the bone marrow assessment. They're all either assessed by the CT or the anatomical assessment, or sometimes both a CT and PET. And then FDG avid lesions and bone marrow will be primarily using the FDG uptake as an assessment methodology, plus sometimes the clinical data may be used for the bone marrow. For our first lesion category, the target lesion, which utilizes the CT assessment as a primary modality, their requirements for the target lesion number would be maximum of the 6 targets or no more than 6 per subject. And there is no limit of the numbers per organ that is specified in the classification, but it recommends to include any mediastinal or the retroperitoneal lymph node involvement if there is present, which should be representative to most of the lymphoma disease burden. Also, the target lesion should be selected based upon a size, reproducibility, and also the disease burden representation, which the most of the response criteria would recommend for the target lesion selection. Size has to be also meeting the measurability requirement we just discussed, the nodal of 15 millimeters or greater in longest diameter, and extranodal for 10 millimeters or greater. Also, on top of that, in case where lymphoma is FDG avid subtype, target lesion also should be FDG avid lesions on the PET scan. And data collected for the target lesion would be simply a lesion ID and the location, record short axis, long axis at the baseline, and also calculate the product of those two values for each lesions. And lastly, we'll be calculating the sum of all the product value of each lesions as a total sum. Upon a follow-up, we'll still follow up on the same lesion ID and the locations, remeasure the short axis, long axis, and also the product of those short axis and long axis. There are cases where the lesions are responding and lesion may get too small. We would apply the same rule for too small to measure with the placeholder of the short axis and long axis of being 5 by 5. If any bigger or if it's possible to be measured by the reader, they would actually put the actual value or the measurement. And then once those are all measured, we would also record the sum of the product of the diameters. Also, additionally, we would want to calculate the absolute change of the short axis, long axis compared to the baseline or the designated nadir from the past time points, and then also the percent change of the sum of the product of the diameter. And these would be the values that will be used to calculate whether the lesion from the target lesions are actually progressing or responding later on for assessment of the responses. For the non-target lesions, also primary modality to be used would be a CT. No really number limits like a target lesion. Also, there is no size requirement. So basically, any measurable lesions that were not selected as the target lesions or truly non-measurable representation of lesions again, going under the non-target lesions. Upon a baseline, we would either, of course, measure the lesion, record the lesion ID and locations as standard information to be entered. Also, the tumor state will be recorded as a qualitative assessment. At the baseline, it would be present. Upon a follow-up, it will be either absent, which is not visualized in the CT anymore, or stable, regressing, and then unequivocally progressing to denote that lesion are progressing. Next one is a new lesion. New lesion would be either any new lesion appearing in the CT or the PET. And with the CT scan, if the nodal lesions getting bigger than 15 millimeters or greater in their longest diameter would indicate the new nodal lesions. If any extranodal lesions, that would be in any size in extranodal area, which is an unequivocal metastasis. With the PET scan, any new FDG-avid focal points that is consistent with lymphoma will be considered as a new lesion with the FDG uptake. We record the new lesion ID and the location for that new lesion appearance, and it will be assessing either at the follow-up, if it's a CT scan, visualize new lesions, we'll either simply record no new lesions, indicating there is no new lesions. If there is any new lesion appeared, reader will either record as an unequivocal new lesions, which will directly correlate it to the progressive disease, or equivocal new lesions, which may be confirmed in the next visit with the backdating if those new lesions were actually a true metastasis from the next follow-up. At the PET scan, it will also be the same delineation of no new lesions or equivocal or unequivocal new FDG-avid foci. For the spleen measurements or spleen assessment, they do typically use a craniocaudal measurement, also something referred to as a vertical length measurement. It will be used through the CT, and they will record the baseline vertical length and a spleen state. So the actual vertical length of the spleen size will be recorded with the state of either splenomegaly or normal, also referred to as a no enlargement. In case the size is 13 or greater than 13, it would be a splenomegaly, and below would be no enlargement. Upon a follow-up, we will still measure the vertical length, state, and the change in the stair size. So record the spleen size itself, spleen state, based upon the size, either splenomegaly, worsening, improving, or if less than 13, would be a no enlargement as a state. And then we'll be calculating these three, which would be a length beyond the normal, which is the actual spleen size minus the 13, which is standard size. So that difference in that 13 to the actual size will be recorded. And then we'll be also calculating the percent change of that length beyond the normal. Also, we want to record the absolute change from the baseline spleen size as well. Just to denote the actual spleen size measurement, or also something referred to as a craniocaudal, is the actual vertical straight line of that spleen, which is often not recommended to directly draw the line through the coronal view of the CT, but we would rather use the actual images counts from the axial slides. So we'll be calculating all the spleen visualized axial slices, count the image slices, multiplied by the slice thickness, which should be the interval between the images to actually calculate the actual length of the vertical straight line from top to bottom. And for the FDG-avid lesions, there is no size or the number requirements, no lesion IDs associated for the FDG-avid lesion assessment. It will be based upon a semi-quantitative scale, something called the Deauville 5-point scale. And this is assessment that is visually compared to the mediastinum or the liver to give a score of 1 through 5 for the most single hottest point of the lesions in the entire PET scan. So 1 would be a no uptake seen, and 2, score of the 2 will be given to any single hottest point on the PET scan that is lighter than the mediastinum area uptake. 3, for the any hottest single point of the FDG uptake that is greater than the mediastinum but less than the liver area. 4 being a moderately higher than liver, and then 5 would be uptake of that single hot point or the hot spot markedly higher than liver, or the presence of any new FDG avid focal points compared to any of the prior time points. And on top of that, if there is any hot point that is new areas or the uptake unlikely to be related to the lymphoma, we'll just denote the X right next to the point, which in case if something was given 4, but that is unlikely due to lymphoma, but other biological processes, they would actually put the little X right next to it to denote that. On top of these 1 through 5, qualitative assessment of the general FDG uptake change compared to the baseline or the nadir will be recorded. And those can be delineated to qualitative assessment as below, which should be increased FDG uptake, decreased, no change. And these qualitative assessment also helps the radiologist to differentiate whether the metabolic response would be partial, stable, or the progressive disease in case where the 4 or 5 is either given. This is just one of the quick imaging renditions, how the global scores would look like, and the mediastinum and the liver being a 2 reference organ points. Any focal point that is lighter than the mediastinum or in between the liver or markedly greater than liver, according to the visual assessment by the reader, 1 through 5 will be given as shown in this image. And for the lastly, the bone marrow category would be based on a PET and a clinical data. There's no size or the number requirements in the bone marrow. The reader will assess and record the qualitative assessment based upon an FDG uptake change upon a baseline and a follow-up visits. Following information can be recorded for the bone marrow assessment based on a PET scan, which should be no evidence of the FDG uptake in the bone marrow, reduced, or the no change from the baseline. And then additionally, we would just want to make sure we record any diffuse FDG patterns without any focal lesions, and then also new FDG focal lesions or the recurrent focal lesion that were disappeared but reappearing in the bone marrow area. On top of that, sometimes the clinical data may be assist the reader just to make sure how the bone marrow is responding or progressing. And the bone marrow biopsy would be preferred to be submitted with the interventional radiology image where the needle went in for aspiration or the taking the samples in particular region, just to ensure those areas can be matched with the PET or CT scans when reader is reading. And also additionally a clean finalized report of whether that result was positive to the biopsy or negative result in a bone marrow biopsy. Also, additional information in the clinical data would be a concomitant medication, something like a GCSF treatment, which also can trigger the bone marrow activities, possibly can display or show any FDG uptake increases. And in case of these medications are treated to the patient, there may be a diffuse FDG uptake with any focal lesions. So knowing whether the patient had this type of medication, yes or no, will assist the reader to answer diffuse FDG uptake without the focal lesions are not truly due to the lymphoma, but the medication temporarily causing those image reading assessment in certain ways. So in that case, reader will be assisted with these information to differentiate the responses between complete or partial metabolic responses. And then with all the lesion category assessment, we can collectively add those information to either assess metabolic response or the anatomic response based upon a PET or the CT. So for the CMR or complete metabolic responses, FDG avid lesions based upon a 5-point scale of 1, 2, or 3, with no new lesions shown in the FDG avid lesions. And also the bone marrow should have no evidence of the FDG avid disease or diffuse FDG uptake without any focal lesions. And then knowing that a reader knows that patient is on certain medication that can cause diffuse pattern of the FDG uptake, which could be given a CMR in such cases. For complete anatomic response based upon a CT would be a target lesion and non-target. All nodal lesions regressing back to 50 millimeters or shorter in their longest diameter, and extranodal lesions diameter should be 9 or to 0 millimeters. No new lesions at all on a non-target lesions. And then also spleen showing no splenomegaly, which would be a vertical size of less than 13. And no new lesions with the normal morphology in the bone area of the CT assessment. For the partial metabolic disease, FDG avid lesions should have a 5-point scale of either 4 or 5, and also have a decreased FDG uptake compared to the baseline based upon a qualitative assessment. And there should be no new FDG avid focal points compared to any of the prior time points. And based upon a PET scan read, the bone marrow should have a reduced FDG uptake compared to the baseline, or either diffuse FDG uptake without any focal lesions, additionally knowing with the concomitant medication status as well. For the partial anatomic response, it'd be for the target lesions, some of the perpendicular diameter product of 50% or more decrease compared to the baseline, and then the non-target lesion qualitative assessment of being absent or either present, regressing, or stable would be a partial response. And then for spleen size, 50% or more decrease in the length beyond the normal, which is the actual size minus 13, or simply the no abnormality in the size would be a partial anatomic response. There should be no new lesions upon a CT. And then for the progressive metabolic disease or progressive anatomic disease will be assessed as a follow. So any FDG avid lesion assessment, Doval 5-point scale of score either 4 or 5, and should have increased FDG uptake compared to the baseline or nadir, which would be either baseline being if the smallest point, or if there was any improvement, any time point that would be considered a nadir that's better than baseline. And then if there's any new FDG avid uptake that was not seen in any prior time points, would indicate a progressive metabolic disease. Also through the bone marrow, if there is a new or recurring FDG avid focal points, would also indicate patient is progressing progressive disease in the metabolic assessment. For the target or non-target lesions, reading through the CT assessment, if there is any individual nodal lesions being abnormal with the size of the longest diameter 1.5 centimeters, and also increased by the 50% or more in their perpendicular product of the diameter from the nadir, and also an absolute increase in their longest diameter or shortest diameter from the nadir, more than 0.5 centimeter for lesions that are size in less than 2 centimeters in their longest diameter, or more than 1 centimeter increase for lesions that's 2 centimeters or greater in their longest diameter. And also the non-target lesion assessment. Any qualitative assessment of the unequivocal progression by the reader would indicate the anatomic disease, progressive anatomic disease. For the spleen size, if there were no splenomegaly in any prior time point, it has to be at least 2 centimeter increase of an absolute increase from the baseline or nadir, and then also 13 centimeter or greater, indicating it is in a splenomegaly status now. If there was a prior splenomegaly to be starting with at the baseline, we'll calculate or look at the percent change of that length being the normal. If that length being the normal number has changed more than 50% compared to the baseline or the nadir, whichever is a bit smaller number, or any recurring splenomegaly that has been resolved also indicates the progressive anatomic disease. Any new lesions or any lesions that has disappeared and grows back would be considered to be a progression in such cases. Lastly, the no metabolic response or the stable anatomic disease would be as following, which should be for the PET scan, 5-point scale of 4 or 5, and there is a no change in FDG uptake from the baseline. And then there should be no new FDG added focal points, no change in FDG uptake from the baseline. And then also for the CT assessment, less than 50% decrease in sum of the product of the perpendicular diameter compared to the baseline, and no indication for any progression criteria has been met. For the non-target lesion, not meeting progression criteria, simply absent, stable, or regressing would either be a stable disease, and then also the spleen of not meeting progression criteria, which we just discussed in the prior slices. Should be no new lesions on a CT assessment would fall under the stable disease. There are a few special considerations when reading a Lugano classification. Sometimes there are mixed response between a metabolic assessment and an anatomic assessment. And this would be a different cases when there is an FDG avid lymphomas are being investigated versus non-avid or lymphomas with the variable FDG avidity. For the lymphomas that shows the FDG avid, response to the PET scan is basically a PET assessment of the CMR or PAR or NMR would be actually having CT assessment of being any cases, the PET assessment will basically trump or to win the CT assessment, knowing that lymphoma is always the FDG avid. So any of the complete, partial, or stable, even the progressive disease, if it's the same wizard window, if the PET scan, as far as the PET scan shows the partial or the complete response, overall response can be overridden to the PET scan assessment. And then that would be a same application for the stable disease. And in such cases, any progressive disease on a CT assessment should be any new lesions that has no correlation to the FDG focal points that is concerned for the lymphoma. And for non-FDG added lymphomas or lymphoma with the variable uptake in FDG tracers, primary modality for assessment will be a CT. In such cases, CT will be driving the over response when there is a mixed response. Or if there is a variable FDG avidity, there can be additional information that can be documented in the charter or protocol just to guide the reader, just to derive the consistent over response based upon an evidence or the rationale. For other two considerations, for anatomic assessment, which is a CT assessment deriving CRPR, SD, or PD, it has to be a CT acquisition through the diagnostic quality with the appropriate contrast agent. And it is not recommended to use that low dose CT that comes together as the PET acquisition or the PET scan itself to measure any of the actual distance measurement. And it has to be specified through the charter where this low dose CT may be used. And often cases, if that's allowed, it would be only cases where diagnostic CT was not available due to missed visit or patient not being able to take that diagnostic CT. And in case there is a no progression is going to be met likely, in such cases, CTAC may be substitute for the missing diagnostic, but also should be specified to the charter just for the consistency of the study. Lastly, 5-point scale assessment. There are a few considerations when assessing that 1 through 5 points, is that one of the reference organ being a liver margin or the abnormal region of the liver should be avoided when comparing any focal point compared to the liver, giving a point of the 1 through 5. There can be some patients where hepatic abnormality may be shown. And if there is any diffuse pattern to really find the normal liver area is sometimes could be hard. In such cases, charter specification is needed and also guide the reader judgment to make sure the right area of the region of the lesion liver can be used. But there is no alternative reference organ that can be substituted for the liver at the moment from current publications. Also score 4 or 5 when they actually mention moderately higher than liver or the markedly higher than liver. These are actually specified as a lesion of the FDG uptake greater than the SUV max of the normal liver lesion. And then 5 would be lesion FDG uptake is 2 to 3-fold higher compared to the SUV max of the normal liver lesion. So those are additional specifications that can be added if it's possible to actually measure the SUV max of the liver area or the FDG of the lesions. And this will be end of my slide, and I'll pass my presentation back to Catherine.
Okay, well, thank you, Dr. Kim and Matthew, for the excellent overview of the Lugano reading criteria and imaging considerations. Just to remind our attendees, you can always go back to Merit's website to check out webinars on other reading criteria, such as Resist 1.1, RANO, and PCWG3. So we have now reached the Q&A portion of the presentation. If you have any questions, please submit them now via the Q&A functionality. And while you are sharing those questions, I would like to share with you 2 slides to introduce you to Merit. So many of you may know Merit from our many years of managing clinical trials in ophthalmology. We have served biotech and pharmaceutical companies in their clinical endpoint analysis for over 10 years with a team of medical professionals and seasoned operational support staff. We offer support to our partners in a variety of therapeutic areas, including oncology, ophthalmology, and respiratory. We are based out of Madison, Wisconsin in the United States, but our company has a global reach. We have team members and reading centers around the globe, making it possible to support sites and sponsors from a variety of locations. And Merit is more than an imaging service provider. We are positioned to be an extension of your study team, and we do this by focusing on 3 areas. Our software system, EXCELSIOR, can handle all aspects of an imaging core lab in one system, from acquiring images from a study site to performing an independent read and transferring data to a sponsor. EXCELSIOR can manage and track images every step of the way. Merit also has a large network of over 300 radiologists and oncologists to help support studies in a variety of therapeutic areas. And finally, at Merit, we truly value a partner approach, working closely with our sponsors and sites to build trust, partnership, and long-term relationships. Our proprietary software platform called EXCELSIOR delivers automation in a single system for all image and workflow management, resulting in clean, complete, and accurate data that will meet your clinical trial needs. EXCELSIOR has been used for over 200 studies and is validated and an FDA 510(k) cleared medical device. Our unique role-based software allows all key stakeholders to work within one platform, regardless of their location. And this is so exciting because all data is housed within one system. The images, the workflow tracking, queries, even the read assessment data, it's all in one system, and it avoids the need for multiple software systems to be configured to talk to one another. So now we will open the discussion for any questions you may have. And just as a reminder, if we don't get to your question, we will follow up with it in an email after the presentation. Okay, so let me see here. Okay, it looks like our first question. Matt, I'm going to throw this question to you. In your presentation, you mentioned FDG as a radio tracer that is used during the PET exam for lymphoma. And the question here is, are other radio tracers used?
Thank you for the question. No, so FDG is the only radio tracer that should be used while using the Lugano classification, and it's specifically called out within the criteria that FDG should be used exclusively.
Okay, great, thank you. Okay, our next question, what should the slice thickness be for the CT exams? You mentioned that slice thickness is used to calculate spleen size. Dr. Kim, would you mind taking that one?
All right, thank you very much for the question. So yeah, so just to reiterate, the CT of the CT portion that is required for the anatomic assessment is a diagnostic quality CT, and has to be a 5 millimeter or smaller in their slice thickness, and that is for both to measure the spleen size and also for meeting that requirement for the size of the measurability on the target lesions of the 15 millimeters and the 10 millimeter for nodal and extranodal. So for both the target and the spleen size, the 5 millimeter or less should cover the accuracy of the measurement for the spleen and target. Yep.
Okay, good, thank you.
Mm-hmm.
And this question is kind of a follow-up. If I need to perform both a PET and a CT for a patient, can it be done at the same time through the PET CT you mentioned, or should it be separate?
Yeah, I'd be happy to take this question. So any PET CT that is performed, the CT portion of the PET CT exam is considered to be non-diagnostic. So while it may provide some visual clues, it is recommended that you perform a dedicated, separate diagnostic CT scan on its own.
Okay, so those always have to be
Correct.
separate then. They can't be done at the same time. Two
Yep.
separate exams. Okay, that's good. Okay.
Right.
Okay, and here's another one. This is about, okay, so this is about the types of lymphoma. You mentioned that there were some types of lymphoma that are more FDG avid than others. Can you provide me with a few examples of this?
Yeah, sure. So the types of lymphoma that are typically FDG avid are Hodgkin's lymphoma, diffuse large B-cell lymphomas, also some mantle cell lymphomas as well. And some that don't image very well traditionally are small lymphocytic lymphomas and chronic lymphocytic leukemias as well. But you know, it's very important to pay attention to what type of lymphoma that you are investigating to ensure that, hey, this is the correct criteria, and or hey, we're approaching it with the correct approach, utilizing PET or CT as the primary modality of assessment.
Okay, yeah, and I guess that kind of goes back to the point you made during your part of the presentation that it's important to partner with someone that knows what they're talking about. So an imaging core lab that has experience with this, that can kind of guide you to do, to choose the right response criteria for your particular indication.
Exactly, the experience and the expertise and the training within that.
Okay. All right. Great. Thank you. We're at 11:45 Eastern time right now. So just to be respectful of everyone's time, we have reached the end of our presentation and our Q&A session. I just want to thank everyone for your time today, for spending this time with us to learn more about the Lugano criteria. You can stay up to date on additional primary endpoint related content by following our company page on LinkedIn. Please stay tuned for more information regarding Merit's upcoming webinars, and I hope everyone has a great day. Thank you so much.
Thank you very much.
Thank you. Bye-bye.
Okay, bye-bye.